So the takeaways that I think that the audience are hopefully going to go away and kind of implement in their units is the importance of post-intensive care nutrition and thinking about nutrition after the first week of ICU stay. I think we've really had a focus over the last 20 or 30 years on either the first few days or the first few weeks. And now we're seeing that because patients are staying much longer in the ICU and then they stay much longer in hospital, we kind of forget about them after the first week. So I'm hoping that they take away that it's important to monitor patients through over that continuum of admission in not just the ICU, but the hospital. So I think we know that the accuracy of these equations compared to measured energy expenditure isn't very good. So Penn State, of course, comes out the best at around 60 to 70% accurate compared with measured energy expenditure. But of course, it's different in obese patients, it's different in the elderly, and it's different in underweight patients. So I think tracking energy input, energy intake or delivery compared to prescription is an extremely important part of a nutrition assessment. And we do this in our patients on our ICU. We do have an electronic medical note system, but unfortunately it doesn't do that for us. So we have made an Excel spreadsheet where at least once a week we assess the intake and compared with prescription of our patients. I think this is very important for knowing whether or not we need to do some catch-up feeding with patients or for seeing how far behind in their nutrition they are. And we have seen a huge change in our practice over the years. We actually do regular audits also once or twice a year. We audit a selected group of patients prospectively. And we've seen a really big change. When I first started on our intensive care unit in 2008, we were meeting on average 58% of our patients' energy targets, probably less for protein. We're now up in the 80s and 90%, which we're really proud of. So we do use feeding protocols in our ICU, and I do think that they have a place. My personal opinion on standardized nutrition support is that it's beneficial maybe for the first 48 to 72 hours of ICU admission, and then I believe in individualized prescription. So we have a feeding protocol that the nurses start feeding when the patient is admitted to the ICU, when the doctors have said it's okay to start feeding, they do. And then that is actually based on 28 calories per kilo. Some people might say that's overfeeding, but from our data, we know we don't get anywhere near that. So we aim to overfeed a little bit, knowing that we're going to significantly underfeed our patients. That allows us, if they follow that for 48 to 72 hours, it gives us more of an idea about the clinical state of the patient and whether they're going to stay longer term in the ICU or be discharged early. So come 48 to 72 hours, we then come along and individualize. I think the future of nutrition therapy for our ICU patients is certainly in individualized nutrition therapy. So using tools such as measured energy expenditure, if we can, or assessment techniques to measure body composition, if we can use those, also to measure the effectiveness of our interventions for individualized patients, because one size doesn't fit all. And I think unless we do start moving towards this more individualized approach, then I don't think we're going to move forward in terms of helping improve outcomes of our ICU patients.